Vitamin C, or ascorbic acid, is a water-soluble antioxidant found in fruits and vegetables. It plays a role in iron homeostasis by keeping iron in its 2+ reduced state so that it's more readily absorbed. It's required for the hydroxylation of amino acids in collagen synthesis. Do you remember which ones? That would be proline and lysine. And lastly, it's required for dopamine beta hydroxylase to convert dopamine into norepinephrine. In general, the symptoms of vitamin C deficiency are secondary to its role in collagen synthesis, and we call this set of symptoms scurvy. If you can't make collagen, blood is going to start leaking out of your gums, joints, and other places, and the blood loss will cause anemia. Also, since collagen deposition is a key part of wound healing, you won't be able to do that as well either. This image shows the tongue of someone with scurvy, and you can see the petechial submucosal hemorrhages. Vitamin C is also found in a high concentration in cells in the immune system. The details of what it does in the immune system aren't important for your step 1, but you should know that deficiency can also cause a weakened immune response, which is why taking a vitamin C supplement can arguably help you get better more quickly if you weren't getting enough from your diet in the first place. Excess vitamin C can cause nausea, vomiting, diarrhea, fatigue, and sleep problems. Also, since deficiency prevents iron from being utilized, it accumulates at toxic levels, especially in people who are already predisposed to iron toxicity, such as those dependent on recurring blood transfusions, or patients with hereditary hemochromatosis, which causes too much iron to be absorbed from the diet. Alright, flash quiz time. So, a deficiency in which vitamin causes macrocytic megaloblastic anemia, hypersegmented PMNs, and paresthesias? So this one would be vitamin B12. And for bonus points, if I didn't say paresthesias, what else could it be? That would be vitamin B9. So remember, deficiency of either B12 or B9 can give you macrocytic megaloblastic anemia and hypersegmented PMNs, but only B12 deficiency has neurological symptoms. Vitamin D is a fat-soluble vitamin that comes in several different forms from several different sources. The D2 form is known as ergocalciferol, and you get it by eating plants and mushrooms, whereas the D3 form, cholecalciferol, is in fortified milk and also produced in sun-exposed skin. By the way, the vast majority of D3 that the average person gets is from sun-exposed skin, not from dietary intake. So how is D3 made from sun-exposed skin? It's actually a derivative of cholesterol. Cholesterol is converted to 7-dehydrocholesterol, which in the presence of UV radiation can be converted into D3. As for D2, even though we don't make it using sunlight, when it's made in other organisms, it also requires sunlight to be made. Do you know what it's made from? This kind of blew my mind when I first learned about it, but it's made from ergosterol, which should sound familiar because that's the thing found in cell membranes of fungi, which we target with some antifungal drugs. Everything's connected in the world of biochemistry. So anyway, D3 is the more important version. In the liver, it can be converted to its storage form by an enzyme that's only produced in the liver, called vitamin D25 hydroxylase. As its name suggests, this enzyme adds a hydroxyl group to the 25 carbon on this molecule, which is this one up here. The 25OH form of vitamin D doesn't do much, so to activate it we first have to send it to the kidney. And remember, since this is fat-soluble, it has to use a carrier protein to get to the kidney, which in this case is called vitamin D binding protein, which should be easy enough to remember. In the kidney, an enzyme called 25-hydroxyvitamin D3-1-alpha hydroxylase adds a hydroxyl group to the 1-carbon position, which is this one down here. Now we have the active form, which is 1,25-OH2 vitamin D3, also called calcitriol. So now that we have active calcitriol, what does it do? Vitamin D plays a role in bone metabolism by regulating calcium homeostasis. It maintains plasma calcium levels by increasing intestinal absorption of calcium and also of phosphate. It also reduces calcium excretion from the distal tubules in the kidney and can cause bone resorption to mobilize mineralized calcium. This will be discussed in more depth in the endocrine section. So vitamin D deficiency can cause a disease known as rickets in children, which manifests as soft bones that bend under the weight of the body, which you can see here. There's also a genetic disease that I mentioned in the genetic section called hypophosphatemic rickets, in which the vitamin D receptor is mutated. Do you remember the transmission pattern of this disease? It's actually one of the few X-linked dominant diseases. In adults, vitamin D deficiency can decrease bone density, but they won't bend since they're already fully developed, and this is known as osteomalacia. The bones will break more easily, though. Since vitamin D helps maintain sufficiently high levels of serum calcium, Its deficiency can cause hypocalcemia, which affects physiology in a few ways. Do you remember what those are? One of the main symptoms is tetany, and this happens because having low calcium in serum allows sodium to enter cells, causing depolarization and therefore spontaneous muscle contraction. Hypocalcemia can also cause arrhythmias and seizures. Since D3 is formed in sun-exposed skin, deficiency occurs more commonly in dark-skinned patients. Babies whose diet consists mostly or entirely of breast milk and have minimal sun exposure should receive vitamin D supplementation. Excess vitamin D can cause hypercalcemia, which in turn results in hypercalciuria, since the body tries to get rid of the excess calcium by excreting it into the urine. In addition to excessive dietary intake, hypercalcemia can also be caused by sarcoidosis, in which vitamin D is activated by epithelioid macrophages. Vitamin E, also called tocopherol, is a fat-soluble antioxidant vitamin found in sunflower oil, corn oil, soybeans, meats, fruits, and vegetables. So this is an antioxidant, so I'll ask you, what cells in the body are really susceptible to oxidative stress? That would be erythrocytes. So vitamin E protects erythrocytes from free radical damage, so its deficiency can lead to increased fragility of erythrocytes, which in turn can cause hemolytic anemia. You might also see acanthocytes, which are these spiky red blood cells, for the same reason. Other signs of vitamin E deficiency include muscle weakness and posterior column and spinocerebellar tract demyelination. Also, a great excess of vitamin E can interfere with vitamin K metabolism, so this will have an anticoagulant effect and can be used to boost the effects of warfarin. Alright, so speaking of vitamin K, let's talk about it some more. So vitamin K is a fat-soluble vitamin that is mostly acquired from intestinal flora, but also found in some vegetables and animal sources. It's used to produce the clotting factors 2, 7, 9, and 10 in protein CNS. So where are these produced? That would be in the liver. So vitamin K is used here for a step called gamma carboxylation of glutamic acid residues on these proteins. This mechanism is discussed in more detail in the Hem/Onc chapter, but for now keep in mind that it involves oxidation and reduction of vitamin K, and the enzyme epoxide reductase converts vitamin K from its oxidized to reduced form. The drug warfarin inhibits epoxide reductase, thus inhibiting the function of vitamin K, which in turn prevents the gamma carboxylation required to reduce clotting factors. You should keep an eye out for vitamin K deficiency in neonates since they have sterile intestines or in anyone who's been taking a lot of antibiotics, since the primary source of vitamin K again is intestinal flora. People who are deficient in vitamin K can't produce enough clotting factors and are at risk for hemorrhage. Labs will show increased PT and PTT, but a normal bleeding time, since platelets still function normally. To prevent this, neonates are given intramuscular injections of vitamin K at birth. Zinc is a physiologic ion that's essential for the function of over 100 different enzymes, and it also helps proteins such as zinc-fingered transcription factors achieve the structure they need to function properly. Here's an image of part of a zinc-fingered transcription factor in which you can see the protein in blue and the zinc ion in green. Without zinc, the protein can't fold properly. Deficiency in zinc can prevent a lot of proteins from working properly and therefore causes a lot of different types of symptoms. Some of the main examples are delayed wound healing, hypogonadism, decreased axillary, facial, or pubic hair, dysgeusia, which means distortion of taste, and anosmia. It can also predispose patients to alcoholic cirrhosis. Alright, this will be our last flash quiz for the nutrition section. So a patient presents with tetany. Which vitamin deficiency could cause this and by what mechanism? So tetany can be a symptom of a pretty extreme vitamin D deficiency, and the reason is that the patient would have hypocalcemia, which causes tetany. Alright, we'll finish off nutrition by going over malnutrition. So kwashiorkor is a state of specifically protein malnutrition, which manifests as skin lesions, edema, anemia, and liver malfunction with fatty change. Okay, so why is it the case that protein deficiency causes edema? It's because proteins such as albumin maintain the oncotic pressure of the vasculature, without which fluid can leak into the surrounding tissue, which is edema. The clinical picture of kwashiorkor is a child with thin limbs and a swollen belly, which again is caused by edema. Marasmus, on the other hand, is an energy malnutrition in which there is insufficient overall caloric intake. These patients aren't able to store any calories as fat, and are consuming anything they can in their body to make glucose to keep their vital organs functioning. The lowest priority tissues are fat and then muscle, so these patients present with tissue and muscle wasting, loss of subcutaneous fat, and depending how much protein they're getting, sometimes they'll have edema too. It's important to remember that unlike marasmus, kwashiorkor can occur in patients with a normal caloric intake, as long as they're receiving a very small amount of protein. Alright, ethanol metabolism. So this is something that some of you might be doing soon after taking your Step 1 exam, but you can feel better about it if you know how it works before you take your exam. So the reaction for the metabolism of ethanol is shown here. It's first oxidized to acetaldehyde by the enzyme alcohol dehydrogenase, which takes place in the cytosol. Next, acetaldehyde is further oxidized to acetate by acetaldehyde dehydrogenase. Notice that the second step occurs in the mitochondria, not in the cytosol. This is an important point that might show up in your test. So in both steps, NAD is used as the oxidizing agent and is the limiting factor in this reaction. Alcohol dehydrogenase operates via zero-order kinetics, which means its rate does not change based on the concentration of alcohol. Several medications can be used to treat alcohol poisoning and to maintain abstinence in alcoholics. Fomepizole inhibits alcohol dehydrogenase, but it is not used in situations involving excess ethanol. Instead, it's used as an antidote for methanol or ethylene glycol poisoning. This is because alcohol dehydrogenase is also used to convert methanol to formic acid, which causes visual disturbances in methanol poisoning, and also converts ethylene glycol into glycolate and oxalate, which cause renal damage in ethylene glycol poisoning. Acetaldehyde is responsible for the symptoms of a hangover after excess alcohol consumption, and disulfiram, or Antabuse, is a drug that inhibits acetaldehyde dehydrogenase. So this is actually a bad thing physiologically, because it causes a buildup of acetaldehyde, and therefore causes more severe hangover symptoms. Therefore, this drug is used to condition patients to abstain from alcohol in the future. If you think about it, it's easier for a patient to make the decision when he gets up in the morning that he shouldn't drink that day and just take a pill, instead of having to make the decision later when he's watching a football game with his friends. A third alcohol abuse drug, which we'll discuss more in the psych chapter, is naltrexone, which is an opioid receptor antagonist. Therefore, this is a centrally acting drug that's used for alcoholism. One consequence of chronic alcohol use is fatty liver, or hepatosteatosis. You can recognize this in a liver section by all these big white circles, which are big lipid droplets. So why does chronic alcohol use give you hepatosteatosis? This happens because alcohol disrupts the normal pathway of glucose metabolism. Remember, the metabolism of ethanol requires the reduction of NAD to NADH. Thus, alcohol use will decrease the amount of NAD available and increase the amount of NADH. Now, the ratio of NAD to NADH is an important thing in cells. The metabolic reactions that use either one or the other of these can now be forced to go in a specific direction. The two main reactions I want to point out are the interconversion of pyruvate and lactate, which is shown here, and between malate and oxaloacetate, which is shown here. When the balance is shifted such that there's a lot more NADH than NAD, which is what happens in chronic alcohol use, pyruvate will be converted into lactate to consume some of this excess NADH, and likewise, oxaloacetate will be converted back into malate. So basically, we're depleting the cell of pyruvate and oxaloacetate. And how is this going to affect metabolism? As you can see by looking at where this fit into the big picture here, since oxaloacetate and pyruvate are the starting substrates for gluconeogenesis, this means that alcohol intake has an end result of preventing gluconeogenesis. This is the cause of hypoglycemia seen in chronic alcoholics. Higher NADH to NAD ratios also favor fatty acid synthesis, which utilizes NADH, and therefore causes hepatic fatty change seen in this image. So what else would you see on histology? Well, you might see some Mallory bodies, which are these dark kind of red spots here. Mallory bodies are made of keratin and are common in alcoholic hepatitis and cirrhosis. But can you think of any other diseases in which you might see them? Some examples are Wilson disease, primary biliary cirrhosis, and hepatocellular carcinoma.